Thank you, Dr. Prabhakar. We come to the last talk of this session, which is to be delivered by me. Before I start, I would have to acknowledge the help that we've got for this particular presentation that I'm going to make. The work that we've done was funded by BMS and under the guidance of a lot of people. One of them is sitting here, Dr. Partho Mukherjee, Professor Abhijit Choudhury, and everybody working in the district of Birbhum, where we've collected some data related to metabolic disease in the state of West Bengal in that particular district. So starting off from where the previous speaker left, on the 14th of November this year, the IDF released the new Diabetes Atlas, telling us that now India has about 73 million people with diabetes. So that's about 7.5 crore people with type 2 diabetes. And this is government statistics. And by 2045, India will have about 13.5 crore, that's 134 million people with type 2 diabetes. What's interesting to note is that you have a huge number of individuals who are not getting the benefit of the talks that we just heard. We know so much about science, what progress we've made in terms of drugs, in terms of technology, but what are we able to deliver to our patients? Because that's the number. If you look at SEA, that's Southeast Asia, you see that block there, that about 60% of individuals probably are undiagnosed with diabetes and diabetes-related complications. And if you look at China, which probably has 53.6% of individuals with that number who don't even know that they have diabetes. In India, it's about 60% of all our type 2 diabetic individuals don't even know they have diabetes. First of all, the patient will have to know he has diabetes before we can even do anything about it. So that's the first major challenge, undiagnosed disease burden. And if you look at the amount of money that's spent in terms of diabetes management, India ranks 4th in terms of the total money spent. But when you look at the amount of money spent per patient with diabetes, India is not there in the top 10. So it's just the sheer number of individuals. That's why any pharma industry would love to come to India, because you can sell drugs. Even if X proportion of the population gets treated, it's enough money for industry. But when you're talking about healthcare of an individual patient, we are pretty rubbish. What's interesting to note that in 1947, when India was independent, 2/3 of all deaths in India were because of either mother and child care related issues or because of infectious disease. If you look at the last census report, you will find that 63% of all deaths in India is because of non-communicable disease, which is predominantly diabetes, hypertension, dyslipidemia, obesity, smoking, COPD, and cancer. And in spite of this being such a huge problem, the government of India only woke up about 3 years ago with a NCD program. You had tuberculosis program, malaria program, polio eradication program, so many health programs by the central government which got rolled out by the state government. But we only have this NCD program which was rolled out 3 years ago. That too as part of, kind of experimental stuff that they were doing. They've had another new document presented this year, but it has been created in somebody's office, not people who work on ground reality, far away from the world. They've talked about opening up NCD cells in terms of having places where people will come to have their non-communicable disease treated. I already told you 60% of our patients with type 2 diabetes don't even know that they have diabetes. So who's going to come to that NCD cell? This is the NCD deaths that I was talking about. 60% of all deaths is because of NCD in India as far as last year's data is concerned. And we all know about what all contributes towards this increased risk of cardiovascular deaths. Let's not talk about it. What's interesting to note is that unlike the Western world, we are different in terms of our metabolic disease. When I was a medical student, our teachers used to teach us that diabetes is a disease which occurs after the age of somewhere around 50. Type 2 diabetes after the age 50. Right now in India, 70% of all diabetes occurs before the age 40. And we heard from the previous talk that one of the major determinants of complications of diabetes is duration of disease. So 70% of the disease occurring before age of 40 tells us that during the lifetime of that individual, there's huge risk that the individual will develop diabetes-related complication. There's another slide that I've skipped there, is that 10% of all myocardial infarctions and sudden cardiac deaths in Indians occur before the age of 40, which is very different from the pattern of cardiovascular disease in the Western world. So what are our challenges? First of all, I showed you the kind of spending that we have in terms of diabetes. In the United Kingdom, where I worked for about 5 years, the NHS spends about 10% of its entire health resources on diabetes management. In India, the amount of money that's spent on health is 2% of the GDP, which is laughable. And of that 2%, less than 5% is spent on non-communicable disease. Forget about diabetes. And when we are talking about available infrastructure, we know how very well we work. And we also know that a patient who knows his disease does well. Any patient on insulin pump, you will realize it's more important. The individual who's using the pump is more important than the use of the pump itself. In India, for example, in my government hospital where I run a pediatric diabetes clinic, I have about 380 odd type 1 kids. Half of them don't even know how to read or write. Somebody else writes down the readings of the glucometer. And of course, I've talked about the ethnicity and the country-specific differences that we have compared to the Western world. So of course, we have a tougher battle. So all the time we talk about all the progress that we've done in medical science, but there's a huge gap between science and practice. And this is where I hope we can create a model in Birbhum which will then be scalable at a state level, which will then be scalable at a national level, which will probably change the lives of our people with NCDs. So going back to the national program, because whatever model we create, it has to be in line with what the central government is thinking. It's essentially had pilot clinics that I've talked about, and it's talked about principles of delivery of healthcare, but nothing more than that. So we are going to talk about a bit what I would hope is going to be a little bit about implementation research. So like I've said, in India, we've had 3 major issues in terms of health: mother and child care related issues, infectious disease, and non-communicable disease. And since independence, we've had an improvement in mother and child care, though still not as much as we would want. And even infectious disease, even though we have, the outbreaks of dengue or malaria, but still tuberculosis is probably not as big a problem as it was. But who has made these changes? Is it the doctors here? Unfortunately, no. I think the major change in healthcare in India has happened because of 2 reasons. The central government's health programs and the people who've actually rolled it out. That's the Anganwadi workers, the ICD workers, that's the healthcare workers at the grassroots level. We doctors have been very selfish, sitting in cities like Kolkata and doing nothing. And you've got to realize then when you're talking about mother and child care, and when you're talking about infectious disease, the individual who's suffering from that has a health-seeking behavior. If you have fever, you will go to a doctor. If a lady is pregnant, she's likely to go to a doctor. But if you have diabetes, hypertension, or dyslipidemia, which you don't even know you have, you're rather unlikely to go to the medical healthcare system until you develop a complication. That's number 1. Number 2, even if you know you have diabetes, hypertension, or dyslipidemia, or obesity, you are not going to go to a doctor. Because if you go to a doctor, that day's earning is gone. It is not your priority because in most of the situations, you're asymptomatic. So you're not going to seek health care unless and until you have a problem. So here we have to create a healthcare delivery model where the individual doesn't go to the healthcare system, but the healthcare system comes to the individual. That's the challenge of management of NCDs in India. So we have to create a system where the person goes from the healthcare system to the individual's doorstep rather than the other way around. And because the national program does not have any clear pathway beyond the district level, we have several unanswered questions which we've tried to address in our particular study. So that's where Birbhum is in the state of West Bengal. And you might ask me, why did we choose Birbhum? That was because Professor Abhijit Chaudhuri is from Birbhum, and he had access to Birbhum, and he wanted our help as well in terms of designing a project which we could actually roll out. So what we created is what we named as a multi-purpose metabolic healthcare worker. You couldn't have a worker for diabetes and a separate worker for hypertension and a separate worker for dyslipidemia. This is someone who's a class 10 pass out, a local from that particular area, which is similar to the ICDS and the ASHA worker that works for other national health programs. And we broke up the entire project into certain phases, and we've just managed to finish the first bit of the phase. So ethical approval was taken. 60 multi-purpose metabolic healthcare workers were trained. The doctors, some of them are sitting there at the back. They trained up these individuals. They were given the electoral roles because that tells you that these individuals are above the age of 18 because they are likely to vote. And for a population of 5,000, one such worker was appointed. And this individual was trained up enough so that he could go and fill up a questionnaire, so that he could know what was the basic level of understanding of metabolic disease amongst these people living in rural Bengal. They were taught how to measure height, weight, waist circumference, calculate the BMI, check the blood pressure, and check a capillary blood glucose using a glucometer. So you have 9 blocks in the district of Birbhum, and the entire population has been divided according to the geographical location as cases and controls. So each of these individuals were given that list and told, go to these people and collect the data and the sample. So they would go early in the morning. On day 1, if they found 1 person, 2 were not there, they would have to go back again and collect the data so that the data was complete rather than having piecemeal data collection. So in the first phase, the questionnaires were filled, the anthropometric measures done, and almost 110,000 individuals have been covered, and I'm going to present to you data of 90,000 individuals that we have data on right now. In the second phase, which we hope once we get more funding that we will do, is going to create awareness amongst individuals with regards to the metabolic health. Now we know at the end of the phase 1, we have all the questionnaires there. It will tell us what's the level of understanding or knowledge about metabolic health is amongst those individuals. In the group that we call cases, we will have these multi-purpose metabolic healthcare workers going and educating this population with regards to metabolic health in terms of small groups, one-to-one and large group discussions. And at the end of this phase, we will collect questionnaires from both sides, that's the cases and controls. And this will tell us whether these multi-purpose metabolic healthcare workers have been able to create awareness about metabolic health disease at the end of phase 2. And after that, we would be collecting venous blood samples as well. Parthoda is sitting there. Parthoda and Professor Chaudhuri, they've created a central port in a place called Nagori, where a lab has been set up. So from the venous blood samples that will be collected there, HbA1c and fasting glucose results I'll be showing you. The other things will also be collected and kept there to form what we hope and pray will be a kind of an Indian mini Framingham. So the test that cannot be done there, it will be transported to Kolkata, and that's where the tests will be done. At the end of sample collection, we will identify individuals on both sides and label them as red, green, and yellow. The green ones meaning that they don't have any metabolic disease. The red ones mean that they have already established metabolic disease, and the yellows are at risk. Now, with regards to phase 3A, we will be then trying to prevent metabolic disease at grassroots level. So these multi-purpose metabolic healthcare workers would know how many yellows they have in their group. So in the cases, they will be visiting these yellow people on a regular basis and try to figure out what they have really been doing in terms of prevention of disease. Have you quit smoking? Have you cut down on your oil intake? Have you cut down on your salt intake? Are you exercising? Have you given up your motorbike and are you again cycling to your field? So things like that. So in the cases, you'll have active intervention for 3 years. So at the end of that phase of the study, you will compare the yellows in the cases with the controls, and you will be able to determine whether such an intervention is being able to prevent progression of metabolic disease. The third group would be in terms of disease management. So these multipurpose metabolic healthcare workers would know which one of them have metabolic disease. That's the red group. The primary healthcare centers of both sides, that's the cases and controls, will be trained up on basic management of metabolic disease, and they will be provided with medicines and all the investigations that are required for management of diabetes, hypertension, dyslipidemia, obesity, and such. This multipurpose metabolic healthcare worker will be after this particular red gentleman or lady to see whether this person has actually been taking the drugs, would be asking him or her, what's your HbA1c? Have you had your eyes checked? Have you changed your footwear? Have you had your annual tests done? So at the end of 3 years, we will look at mortality and morbidity data in the two red groups, that's the cases and controls, and come up with results to tell us whether such a model will be able to help us to actually deliver metabolic health care better. So with all of that in mind, let me just show you certain other things. So you can see we've learned a lot of things, including how difficult it might actually be to take weight. Because on the mud, if you put your weighing machine, you can't weigh. You've got to provide them with a wooden plank as well to take weight. So they've gone to individuals. So let's have a very quick look at the preliminary data, because I think we are running short of time. So that's the age distribution, and not surprisingly, India is a young country, and you can see most of our population is below the age of 50 in terms of individuals that we've looked at. There is relatively no gender bias. Probably we had more females because more females were at home when this particular multipurpose metabolic healthcare worker went over. The men were out working. And Birbhum is a pretty funny district because it's got a very good mix in terms of ethnicity as well as tribal, non-tribal, OBCs distribution as well. And if you look, what is surprising is the baseline blood pressure is pretty high. The weight isn't that high, but the baseline average blood pressure, the mean, is pretty high. And as you can see, in terms of gender specificity, metabolic disease in women in rural Bengal is much higher than men. This is something that we found, and we've even found that mortality and morbidity in women is actually higher than compared to men, and that is in keeping with a lot of other studies from various parts of India. What's interesting is that India is still in the transition in terms of nutrition. So if you look at underweight, you will find there's about 37% of individuals who are underweight. And again, you have about 17% individuals who are either overweight or obese. And in both of these groups, not only the underweight group or the obese or the overweight groups, diabetes is very common. So what we hypothesize is, whatever your baseline body weight is, if you put on weight in terms of even 2 BMI percentage points, that weight gain is essentially fat gain, and that's metabolically bad, and that's what causes diabetes rather than your absolute BMI. And if you look at the waist circumference, not surprisingly, the women tend to be having greater prevalence of obesity. Like I was saying, they have more metabolic disease. Hypertension, almost 1 in 5 in rural Bengal has hypertension. pretty alarming. And when you look at glucose and diabetes, we were really shocked with the data. Now, what we had done was we had given them a glucometer to go and check blood glucoses at home. So we took a random cutoff of anything less than 100 as normal. And the rest, so you can see about 50% of individuals had a random blood glucose less than 100. From the rest, we did a sampling of venous plasma glucose as well, which was a fasting, as well as HbA1c. And surprisingly, rural Bengal now has 17% of the individuals in rural Bengal has diabetes. So overall, IDF was telling us that India, probably 10% of the adult population has diabetes. I think it's a gross underestimation of what the real problem is, because we've done similar studies in Kolkata as well, where we've looked at Kolkata police forces, people working in Kolkata police, prevalence of diabetes is 28%. And you would hope and pray that people working in the police forces are the healthier part of your population. Unfortunately, no. And if you look at the pre-diabetic population, 15% of the population living in rural Bengal has pre-diabetes. Now, what's even worse is when we looked at the responses of the questions that they were asked. Most of the questions in the questionnaires that was there, people said we don't know, or they didn't want to answer, which clearly told us that they didn't know the answers. And when we asked what happens is diabetes, is it a disease where the blood glucose increases? Only 1 in 5 was actually be able to tell you that diabetes means increased blood glucose. Other people responded that it means when the blood glucose goes down. So if that's the kind of knowledge that individuals have with regards to diabetes, what am I going to do and what are you going to do in terms of managing diabetes? And when we asked about, what population do you think is at risk of diabetes? As you can see, the blues are no responses. Only about 1 in 5 or 1 in 6 were able to actually answer the groups of individuals who are actually at risk of diabetes. And when we asked about the complications of diabetes, the results were even worse. And when we asked about what are the risk factors of diabetes, very pathetic results. And when we asked, can diabetes be asymptomatic? No surprises, because this clearly tells us that why 60% of patients with diabetes are not diagnosed to be diabetes, because they're waiting for symptoms to happen. And several of the other questions, for example, when we asked, is an afternoon nap good for prevention of diabetes? Some said it's good. Others said in terms of restricting sweets is perhaps good for prevention of diabetes. And when we said, if someone's got a good or a normal blood glucose now, do you think that an individual can develop diabetes later on? So should the person have repeated screening tests? Most people didn't know the answer to that either. So I can be either be very, very pessimistic and say, God help India, or I can be very, very opportunistic and say, I see great opportunities in my land. We have huge opportunities of improvement. We can all try and work together and create awareness, improve understanding and education, and go for screening programs, mass education, and creation of systems which will actually help us, rather than crying about, we have so little knowledge. The problem is not so little knowledge. The problem is we are unable to deliver what we already know. I shall stop there for any questions. Thank you very much.
Statement here. You are working in the field of non-communicable disease. Don't get disheartened, because even in maternal and child health, where you said there is a health-seeking behavior, 2 major indicators are number of visits, ANC visits, and full immunization. In both of these, in India, almost all the states, the percentages are extremely low. So you need not get disheartened.
I'm not disheartened.
You have a future, good future.
Thanks. BMS World, Bristol Myers.
BMS Foundation. You know, it is gratifying to hear that something is being done, and that you're not just sitting in Kolkata and forgetting about this. It just reminds me of another project that API has been very involved with, called the Sevak project. And so this is very similar to that, at least on the surface. I remember this is Dr. Thakur Patel is the one who started that project about 10 years ago. And again, it's very, very similar as I remember it, though their ratio was, I think, 1 to 1,000 or something like that. So one worker for 1,000 population, and they do exactly the same thing. So do you have the data from that project to compare?
I don't. And actually, I think one of the reasons why I actually wanted to present this today is we have an August gathering here, and we would like people to get involved in this project in terms of, you could help us, not necessarily financially, but, be part of the project in terms of technology transfer, how we store the blood samples, just like Framingham did.
Yeah.
And we could all work together to actually create a model which then becomes scalable, not just on a state level or a national level, but can be a model which can be used anywhere in the world where resources are.
This can be a very interesting thing. I mean, obviously, to know and to understand is the first step towards conquering, I guess. And so, if the 17% figure in rural Bengal, what is it in rural Gujarat, for instance? And is it similar? Is it different? It'll be very interesting. So I'll help you get in touch with Dr. Patel, and then maybe he has some data that you can compare.
Thanks.
But great work.
Thank you.
And a great presentation. Thank you.
Thank you. So that brings us to the end of this session. Thank you very much.